Endoscopy represents, of course, the first line examination and most reliable way to get a precise information, bidimensional information about the mucosal spreading of the squamous cell carcinoma of the upper digestive tract. But in the last year, we have a lot of improvement in this field. Some new tools have been introduced to enhance the conventional standard white light in order to provide a deeper inside information in the specific biological properties of the lesion. It's not a new concept. In the 1970, Professor Strong from Boston introduced the vital staining, told in blue. Then we moved to autofluorescence and the contact endoscopy introduced by Andrea. And the newborn is the narrowband imaging that has been designed to detect vascular changes such as caliber, morphology of the intrapapillary capillary lobes. If you look at the endoscopy, the literature, the contact endoscopy has very good results in terms of sensibility and specificity, but is a way there is a need to have a pathology in OR to interpret the cytology. And also, this technique is penalized by the high cost and the low reproducibility. Also, autofluorescence is well known, but is penalized by the high number of false positive due to the difficulty to distinguish inflammatory diseases from neoplastic disease. And then finally, probably the NBI is the most prominent tools to better define the superficial spreading of the lesion. And the principle, physical principle, based on the filter light. The blue light centered at 450 nanometers corresponded to the main peak of absorption of the hemoglobin and penetrate the superficial mucosa to a depth of 0.16 millimeters to enhance the intrapapillary capillary loops in the superficial layer. The second wavelength is centered at 440 millimeters with a depth of penetration of 0.240 millimeters and make visible the deeper layer of the submucosa and the deeper vessel. So in the last decade, we observed an incredible increase of number of papers about the use, the role of NBI in head and neck cancer. And in all sites of the head and neck, we observe a higher accuracy compared to the standard white light endoscopy. But we have a bigger improvement in the larynx, where we have an average of 21% of gain of benefit in the diagnosis of neoplastic lesion and neoplastic lesion. A relevant issue for most authors is the learning curve of NBI technique. An increased learning curve is necessary in order to reduce the number of false positive and, of course, the need of unnecessary biopsies. Isabel Villaseca, she came from the group of Barcelona, could find that after approximately 200 examinations, a plateau is improvement was established. So in our experience, after a few months that you use routinely, you can reach this plateau very easily. This is an example of the same lesion detected by, visualized by the normal standard fiberscope coupled with the HD camera with a white light NBI. This is the same lesion visualized with the standard video endoscope, and this is the new generation of high definition video endoscope. And you can see the huge difference in the visualization and magnification of the lesion. And of course, with NBI, we was enhance the detail of the vascularization of this lesion. This is another example of the same lesion detected, visualized by again by the normal fiberscope, and again by the standard video endoscope, and finally by the new generation of high definition video endoscope. So you have a very nice magnification. You can appreciate the detail of the lesion. Of course, you can appreciate the vascularization in the lesion and the surrounding tissue. So to have this kind of margin, of course, you have to be very close to the lesion to appreciate the detail. So the aim on biological endoscopy are mainly to get a tentative diagnosis of a given lesion, a so-called optical biopsy, to differentiate a no tumor, a potentially malignant lesion, precancerous lesion, from adjacent healthy tissue, inflamed mucosa, irradiate areas, and of course, the target is to better define the mucosal spreading. To discover this is new target, but is very challenging. To discover lesion not visible under standard white light endoscopy or synchronous lesion. And of course, it's very useful also to perform a lifelong follow-up of suspicious lesion with early detection of persistence or recurrence of metachronous tumor. You can use in the head and neck to explore a nasal cavity or rhinopharynx rigid angle telescope. In the oral cavity, again, a rigid angle telescope. You can better define the lesion. You have a very easy access. By contrast, in the oropharynx, hypopharynx, and larynx, it's better to combine always a rigid angle telescope, more often in the OR, with flexible endoscopes in the office. There are many classifications in the literature to distinguish, to classify the atypical vascular pattern. Lin introduced this classification and speculate on the possible limitation of FBI in evaluating some head and neck sites due to differences between the different epithelium covering the different areas. But he showed that you can have the dark spot prevalence higher in a very thin epithelium without keratinization, and also in pseudostratified ciliate color epithelium. Unfortunately, in this paper, there was a lot of cases of larynx, so it's not possible to compare the prevalence of dark spot in the epiglottis, for instance, in the remain part of the larynx. Wong introduced this type of classification regarding the nasopharynx and nasal cavity, and introduced a new concept of light crest and the difference between the two sides of a rhinopharynx. The light crest, as is normal view, is due to the reflection of the light in the lymphatic tissue, and he supposed that when the light crest, that the normal visualization disappear, and you can detect difference between the two symmetric sides, of course, you can be sure that you face with some neoplastic process. Of course, the NBI is useful only in selected cases, high-risk cases, not in very advanced cases, because it's not useful in this setting. This is an example of a tumor of neoplasia of the nasal cavity. This is an examination with the white light. We shift to NBI endoscopy. You can appreciate the dark spot in the lateral wall of the nasal cavity. This is very useful because you can target your biopsy exactly in the suspicious area. This is another example of normal hypertrophy of the lymphatic tissue when you can appreciate the light crest that is the normal visualization, normal reflection of the light in the lymphatic tissue. By contrast, in presence of carcinoma, you can appreciate abnormal vascularity and irregular vascular pattern, and the light crest disappear completely. So the sign that you have to look for in the nasal cavity nasopharynx is the absence of the light crest and the difference between the two sides that are usually symmetrical. Takano introduced this type of classification for oral cavity lesion, and he confirmed that when you can appreciate some abnormality in the morphology, length, caliber of the vessel, the intrapapillary capillary loops, so type 3 and type 4, of course you have a high probability to have an histology positive for a preneoplastic or neoplastic lesion. So this is very useful classification in oral cavity. This is some example to distinguish suspicious versus not suspicious lesion. This is oral cavity chronic inflammation. If you look in NBI, you cannot appreciate any atypical vascular pattern or atypical dark spot. So with this type of examination, you can easily follow the patient without the need of biopsy. By contrast, in this erythroplakia of the soft palate, with NBI, you can better define the spreading of the lesion, and you can appreciate the dark spot inside the lesion. So in this case, you can have a precise idea about the histology. You presume the histology of the lesion that turn out to be neoplasia. These are another interesting cases where you can appreciate this erythroplakia of the border of the tongue, but again with NBI you can better distinguish the superficial spreading, also to recognize the typical dark spot in the well-demarcated area. So it's very useful to evaluate the spreading of the lesion and to define the margin for the excisional biopsy. You can appreciate the difference between the white light, the suspicious area detected by white light and detected by NBI. This is another interesting cases where the patient had neck metastasis without visible primary at a normal endoscopy MRI. But if you look with NBI, you can recognize a suspicious area in the left palatine tonsil. So in this case, you can target your biopsy and confirm the primary tumor. So you can see some atypical vascular pattern on the left palatine here, tonsil. You can see here the spot where we took the biopsy to confirm the histology of the lesion, not visible with the standard workup. It's also useful in the oral cavity to follow the patient. For instance, this is the case that we follow for 2 years without any atypical vascular pattern, but after 2 years we appreciate this change, the appearance of this atypical pattern that was confirmed to be microinvasive carcinoma after a target biopsy. So it's very useful also to follow the patient and to emphasize enhance the suspicious area. About the larynx, the ELS recently introduced a very simple classification, dichotomic classification, based on the direction of the intrapapillary capillary lobes. So divided in 2 groups, the lesion characterized by the longitudinal direction of the intrapapillary capillary loops in terms of dilated vessel, meandering, or winding tortuous vessel, but always in the same direction. So it can change the caliber, but is always in this direction. This is characteristic of every benign lesion. By contrast, when you have the change of direction of the intrapapillary capillary from the deep layer to the superficial layer, in terms of dark spots or a large vessel on the loops inside the lesion, and the dark spots are usually the apex of the loops, the probability to find histology ranging from dysplasia to carcinoma is very, very high. So talking about the larynx, usually we face with some lesion like leukoplakia. With the standard endoscopy, you cannot presume the histology because the appearance is very similar, even if the histology is completely different. By contrast, in the erythroplakia, you can appreciate with NBI the atypical dark spot inside the lesion, and also the vessel that change direction inside the lesion. So with NBI you can appreciate more, you can see better, and also you can define better the limits of the lesion compared to the standard endoscopy. And of course, probably with NBI, this is a very old picture. Probably nowadays with NBI you can probably appreciate some atypical vascular pattern inside the lesion or in the surrounding tissue. This is an example of better definition of the lesion. Sorry. In the office. So in the office you can appreciate just a small erythroplakia with a white endoscopy, but turn out in the NBI you can see some suspicious dust spot inside the lesion. This is enough to put the patient in OR to better define the lesion, because with an angle telescope you can go very close to the lesion. You can better define the vascularity, and of course you can appreciate much better the dark spot inside the lesion. And with the 70 degree, you can appreciate the extension to the subglottis of the floor of the ventricle. So you can mapping exactly the extension of your lesion, and you can define much better the superficial, the mucosal extension of the lesion, and plan in this way your resection in terms of excisional biopsy. This is the case where we perform a subligamental chordectomy with a CO2 laser, keeping good margin, at least 3 millimeters, and keeping in your mind that the previous information that you got with the NBI exploration. So this is very important to have a complete resection of the lesion in free margin, and you can unify in the same procedure diagnosis of the entire lesion and the final treatment if the histology confirm the clear margin of the resection. So this is the goal of TLM, to simplify the treatment in order to have a unique procedure to have a diagnosis treatment, and of course to spare as much as possible the multi-layer structure of the vocal cord to reach a compromise between the oncological radicality and the functional outcome. So in this case, the specimen include the mucosa, the vocal ligament, and I try to spare as much as possible the vocal muscle. This is another case of early detection of not visible lesion. Again, in the office, this patient was already treated by laser, and during the follow-up you can appreciate just a small erythroplakia on the right vocal cord, close to the anterior commissure, but not a really specific one. In turn with NBI, by contrast, you can better visualize the network, the vascular network, and you can appreciate some satellite foci on the right vocal cord here. You can also appreciate some dark spot inside the lesion. So you have a completely different information shifting from white light to the NBI. You can detect earlier your recurrence. This is another case of early detection of recurrence. This is again one patient treated by TLM. You can appreciate erythroplakia in the anterior commissure. It looks like inflammation, something like that, but again, with NBI is become suspicious, and suspicious means that you are obliged to look better in the OR. In OR, again, with the angle telescope, the picture changes completely. You can see loops and a dark spot inside the lesion, and with the 70 degree you can better define the boundaries of the lesion. This is very important in order to plan exactly the extension of your resection and to reach the goal to remove completely the lesion in clear margin. This is very important in this kind of surgery. Of course, is important also when we treat head and neck cancer to detect synchronous lesion. This is an index tumor of the larynx, but during the examination we found a synchronous lesion. Again, with NBI, of course, this is a huge lesion, but is useful, the NBI, to better evaluate the extension of the synchronous tumor in the soft palate. This is very useful to change your therapeutic plane. And finally, during the follow-up, it's very important to detect also metaclonus tumor, that the incidence is around 6%. And you can see a patient irradiated for larynx tumor. We can appreciate in this second tumor, metaclonus tumor in the tongue. And again, with NBI, you can better appreciate the extension of the second tumor, not really visible in the white light. Again, the group of Barcelona, Isabel Vilaseca, performed a critical review of those cases that show discrepancy between clinical evaluation and the pathology report. Because the NBI combine in the aortic tube significantly reduce the false negative and the false positive in the diagnosis. But there are some scenarios in which NBI is not so useful. She underlined that the false negative was due to submucosal tumor, submucosal recurrence, because it's very often to find submucosal recurrence after TLM, because usually the standard endoscopy is negative, but there is some recurrence that you cannot appreciate even with NBI, or in case of no squamous cell carcinoma, for instance, lymphoma or neuroendocrine carcinoma, or again paraganglioma. So every different type of tumor, very rare tumor, are not always detectable in same way as squamous cell carcinoma. By contrast, the false negative are due, most of the cases are due to post-actinic changes or infection or something like that. So it's very important to know very well the clinical story of the patient. This is some example of false positive due to the inflammation, to the post-actinic change. You can appreciate the abnormality of vascularity, but is not concentrated in the well-demarcated area. This is the big difference. And also the density of the dark spot is lower compared to the neoplastic lesion. This is very important to keep in mind. Thank you for your attention.